Hello everyone, welcome back to the series of lectures in pulmonology. Today we will be learning about what we call as the bread and butter of pulmonology, which is bronchial asthma. So let's begin. So what exactly is bronchial asthma? So this is a disease which is characterized by episodic airway obstruction and hyperresponsiveness accompanied by airway inflammation. So the gist of this sentence is that this is an obstructive lung disease. Okay, so bronchial asthma is basically an obstructive lung disease, and a very important point that it is frequently episodic in nature. So there is episodic, please cut the last line. So there is episodic airway obstruction and there is hyperresponsiveness predominantly of the bronchial tree, because of underlying inflammation. Okay. So this is what is bronchial asthma. So let us understand what are the risk factors. What are the risk factors for the development of bronchial asthma? So allergen exposure in those patients who have a predisposition to atopy. So most of the time bronchial asthma is a disorder which begins in early childhood, and these are patients who have a background history of allergic diseases, background history of allergic rhinitis, allergic sinusitis, background history of atopy, urticaria, food allergies, and so on and so on. Right? So in these kind of patients, innocuous stimuli can act as allergens. For example, it can be dust, it can be mites, it can be pollen, it can be just viruses or any air pollution, exposure to air conditioning. Any of these can act as allergens and they can trigger bronchial asthma. So in a patient with a background or predisposition to atopy, allergen exposure can trigger asthma. Secondly, asthma can occur due to occupational exposure to different fumes or different inhaled agents. Third, air pollutions. Fourth, it can be due to infections. Most commonly it is viruses, but even bacteria can trigger an asthmatic attack. Then any form of smoke, including tobacco smoke. Then certain other conditions which predispose or which are considered to be risk factors for asthma includes obesity, diet, and fungi, right? So there has been a new term that has come up which is called as SAFs. Okay, so this is basically standing for severe asthma with fungal sensitization. So common mold that we see is nothing but your aspergillus. So aspergillus we all know can cause invasive disease, but in asthmatic patients it can cause a difficult to treat asthma kind of picture, because this aspergillus or these molds can go and colonize the airways, they can colonize the sinuses, and in turn they can create an difficult to treat asthma because they act as allergens. Okay, and this is what we call as severe asthma with fungal sensitization. A very common form of it, or a more severe form of the SAFs, is your allergic bronchopulmonary aspergillosis. Okay, so there is no invasion, there is no destruction of the sinuses, there is no destruction of the lungs. It is just occurring in the form of a difficult to treat asthma. Then in certain asthmatics, a high intensity exercise in itself can trigger an asthma. This is called as your exercise-induced asthma. Then the next is something called as RADS, which stands for reactive airway dysfunction syndrome. Okay, so reactive airway dysfunction syndrome, or RADS, is basically an asthma-like episode which occurs secondary to inhaling certain fumes or vapors, okay, which may be toxic or non-toxic, and this usually occurs within 24 hours of the inhalation. Okay, so this is about the various risk factors for asthma. So always remember allergen exposure in a patient who has a predisposition to atopy, then occupational exposure, air pollution, tobacco exposure, and we have learned about SAFs and RADS. So let us understand the epidemiology of bronchial asthma. So bronchial asthma is a disorder of childhood. It's more common in children than in adults, but there has been a form in which we describe adult onset asthma. In the children it's more common in boys, but in adults it's more common in women. Okay, so this is about the epidemiology. Now let us understand the pathophysiology and the pathological changes which you can see in the airway of an asthmatic patient. So what are the triggers? The triggers can be allergens. What are the common allergens? It is often dust in the home, or it can be mites. Then it can be AC exposure, it can be air pollution. Okay, then it can be viruses. So all of these can act as triggers. Irritants, viruses, exercise and drugs and even hormonal changes can trigger an asthmatic attack. Okay, so the moment this allergen is activated, what are the different types of pathological changes which you can see within the airway of an asthmatic state? So this is the pathological changes which you find in a asthmatic patient. So we have the normal airway on the left side, and on the right side we have the asthmatic airway. So you can see that normally you have the lumen is quite clear and it is quite big, and here you have the ciliated, the columnar epithelium with the mucus layer, and you have smooth muscles and few cells which are present in the histological section. But moment the asthmatic attack is triggered, what are the changes that you can see? The most important conspicuous thing that you can find is that there is a smooth muscle hyperplasia. There is a smooth muscle hyperplasia. Okay, and there is a cascade of inflammatory pathways which are activated, as a result of which there is a huge movement of inflammatory cells into the bronchial lumen, that you can see that there is a large amount of cellular inflammation, predominantly eosinophils, and in a different type of inflammation called as the non-type 2 mediated inflammation, you can have neutrophils as well and mast cells, right? And the epithelium, which is quite silent in your normal airway, the epithelial cells begin to proliferate and there is excess amount of mucus production. Okay, and the epithelial cells get damaged as well, and there is denudation and shedding of the epithelial cells. At the same time, there is a lot of vascular proliferation, as you can see here, right? So a large number of new angiogenesis takes place. There is a lot of vascular proliferation, and because of this vascular proliferation and vasodilatation, there is increased production of mediators. There is increased movement and increased production of mediators which further worsen the inflammation. And all of these put together is ultimately going to cause narrowing of the airways. Ultimately going to cause narrowing of the airways and bronchoconstriction, which is the classical hallmark feature of bronchial asthma. Okay, so you can see that there is invagination of the airway mucosa, smooth muscle constriction, there is smooth muscle hyperplasia, there is excessive production of mucus, there is excessive inflammation, epithelial damage, neovascularization, and on the whole there is going to be bronchoconstriction, right? So this is about the various pathological features which are found in bronchial asthma. Let us understand the different mediators which are involved in your bronchial asthma. So traditionally, asthma was classified as the atopic type and the non-atopic type. The atopic type is the most common form which is seen in children, and it is usually occurring in the background of atopy or background of an allergic history, and this is associated with the production of an important molecule which is IgE, and it is more common in children. The non-atopic form, which is basically the bronchial asthma which occurs in individuals who do not have an atopic predisposition, is called as your intrinsic asthma, right? So this is called as your intrinsic asthma, and this is more common in adults. Okay, but now the atopic and the non-atopic forms of asthma have been reclassified as your type 2 mediated inflammation and your non-type 2 mediated inflammation, right? So in your type 2 mediated inflammation, what are the mediators that are involved? In your type 2 mediated inflammation, the antigens are going to stimulate the B cells, the antigens are going to stimulate the B cells to differentiate and produce IgE. So very important, the one molecule that you have to remember is that this is due to an IgE mediated inflammation. So can you see here that there is IgE? And what are the interleukins that are involved? They are interleukin 4, 5 and 13. It's very important to know the interleukins, because now we have molecular therapy for asthma which are directed against particularly these interleukins itself. Okay, so the interleukin 4 is the one which is going to stimulate the B cells to produce IgE. The IgE in turn then go and stimulate the mast cells to degranulate. Okay, so this IgE is in turn going to stimulate the mast cells to degranulate. The mast cells are responsible for the contraction of the smooth muscle hyperplasia and hyperresponsiveness. Okay, the interleukin 5 is going to go and stimulate the eosinophils. So, what are the keywords that you have to remember when it comes to your type 2 mediated inflammation is that there is IgE mediated inflammation. The interleukins that are involved are interleukin 4, 5 and 13, and the hallmark cells which are involved is the eosinophils. So, this is an eosinophilic mediated hyperresponsiveness. So, there is a lot of eosinophilic activity in your airways. Okay. So, this is the most common type, and this is the type which is often found in children in the background of atopy. Then, what is this non-type 2 mediated inflammation? In a non-type 2 mediated inflammation, what you have to remember is that the pathways are different. Okay, so here it is a T helper 1 and T helper 17. It is not your T helper 2, it is T helper 1 and 17 mediated inflammation, and the interleukins or the mediators that are involved are 17 and 8 and TNF alpha. Interleukin 17, 8 and TNF alpha. Okay, fine. And this usually occurs secondary to irritants, pollutants, microbes and viruses. So, interleukin 6, 23, 17, 8, TNF alpha are the different interleukins that are involved here. And the cell that you have to remember is the neutrophilic mediated inflammation. It is not eosinophilic, right? So, this is a neutrophilic mediated inflammation. So, this is the major difference between your type 2 and your non-type 2 type of inflammations, the two different phenotypes of asthma that is here. Okay. So, young onset versus adult onset asthma, type 2 versus non-type 2 inflammation. Clear? So, this is about your pathophysiology of asthma. Now, let us understand the different clinical features of asthma. So, how does a patient of asthma present? So, if this is a childhood onset asthma, you have to definitely ask about the background history of atopy and allergies, history of allergic rhinitis. Okay, and how is it going to present? It is usually going to present as episodic airway obstruction, and each airway obstruction episode is usually characterized by wheezing. Many a times they are able to recollect the sound, they are able to hear that wheezing sound. They are characterized by recurrent episodes of wheezing, recurrent episodes of breathlessness, predominantly during seasonal changes, especially more so in the winter or the rainy seasons. Okay, right? So, this is your classical history of asthma in an atopic individuals. Okay, so many a time you may have certain variants. So, one of it is your cough variant asthma, and this cough variant asthma is not characterized by wheezing, but predominantly it is characterized by a dry, hacky cough. Okay, and many of them will also give a history of chronic inhaler use. Okay, so this is the usual history. Then on examination, what are the findings that you are going to find? Okay, so bronchial asthma patient on examination, what will you find? On auscultation, you will find bronchi. Okay, and it's usually a polyphonic bronchi. Okay, fine. Apart from bronchi, what else you can find? You can find that they may have an increased respiratory rate. In your severe asthma, if it is an acute severe exacerbation of asthma, you may also find a silent chest. So, if the chest is silent, be very, very careful, because this could portend a acute severe asthma. So, silent chest is a very, very important finding that you find in acute severe asthma. Most of the time, severe asthma can also be associated with one particular pulse abnormality, which is pulsus paradoxus. Okay. In severe asthma, you usually do not find a type 2 respiratory failure. The most common type of failure is usually a type 1 respiratory failure. But if there is an asthma COPD overlap, or if the asthma has been going on for a very long time, you may find evidence of type 2 respiratory failure, and asterisks may be found if there is a type 2 respiratory failure. But type 1 is the most common presentation of severe asthma. Okay, fine. So this is about the various clinical features of bronchial asthma. Now, what are the differential diagnosis? So we know that asthma is actually a disease which is difficult to diagnose if they do not have the background history of atopy. They may just present with episodes of cough, episodes of chest tightness, dyspnea, plus or minus wheezing. So if the wheezing history is not present, then you may find it even more difficult to find out the diagnosis. So what are the top differential diagnoses of asthma? The first is your heart failure. So the first one is your heart failure, right? So how do you differentiate heart failure from asthma? Heart failure is not episodic. Heart failure will not be episodic. So there is progressive dyspnea. And you may have other associated findings such as orthopnea, and you may have history of pedal edema or abdominal distension. Okay, so orthopnea is not a characteristic finding of bronchial asthma. Can you find wheezing in heart failure? Yes, you can find, and this is what we call as the cardiac asthma. So the bronchi or the wheeze which is found in heart failure because of pulmonary edema is called as a cardiac asthma. So if cardiac asthma is present, it becomes even more difficult to differentiate it from the regular asthma. Okay, so but other symptoms like orthopnea, pedal edema, progressive dyspnea, all of it can help point towards heart failure. Okay, fine, right. And a characteristic, another feature which is very similar to heart failure is that heart failure can have episodes of paroxysmal nocturnal dyspnea. So what is this paroxysmal nocturnal dyspnea? We have learned it in our heart failure chapter as well. So after the patient of heart failure goes to sleep, around 1 hour later, when he goes into the REM stage, or the REM stage of sleep, there can be increased sympathetic activity, right? So there can be increased sympathetic activity, and the failing heart is not able to cope up with this increased sympathetic activity and increased heart rate, as a result of which they get up with breathlessness, and they may have to move towards the nearby window to catch a breath, right? So this PND in fact can mimic asthma. Why? Because these symptoms of asthma, especially during an acute exacerbation, will be more so during the early mornings. They are more so during the early mornings, and hence asthma is also a PND mimic, and that is one of the ways in which asthma and heart failure can be confused. Okay, fine. So that is your first differential diagnosis. Second is your COPD, right? So COPD also presents in a similar way with recurrent history of exacerbation. So how will you differentiate COPD from bronchial asthma? Because COPD is not that much episodic in nature. They will have an underlying chronic dyspnea component. They may have an underlying chronic dyspnea component. Okay, fine. This is about COPD. Then other differential diagnosis can include alpha-1 antitrypsin deficiency and bronchiectasis, because both of bronchiectasis as well as alpha-1 antitrypsin deficiency can result in an obstructive airway component. How do you differentiate? Because these two specifically present with cough with expectoration, and bronchoria can also be present in bronchiectasis, but in asthma it's predominantly a dry cough unless there is an infective exacerbation. Okay. Then other differential diagnosis includes vocal cord dysfunction and foreign body. Foreign body usually results in a stridor because of upper airway obstruction, and this becomes a very important differential diagnosis. Okay, and post-nasal drip. Post-nasal drip is also another important differential diagnosis. Okay, so this is about the various DDs for bronchial asthma. So also we should be looking at the various comorbidities which can be associated with bronchial asthma. Also, we should be looking at the various comorbidities which can be associated with bronchial asthma. So, the first of it is your GERD, which is gastroesophageal reflux disorder, where there can be reflux of the acidic content of the stomach into the esophagus, and this also can mimic asthma to a great extent. Second, there can be associated nasal polyposis, especially in individuals who have a background predisposition to atopy. Another important thing that you have to remember here is something called as Samter's triad, which comprises of asthma with polyps and aspirin sensitivity. Okay, so asthma with polyps and aspirin sensitivity is what we call as Samter's triad. The third association which can make asthma a little difficult to control or difficult to treat is your obesity, and fourth, if they have an associated COPD, and fifth, even an obstructive sleep apnea. So, management of asthma does not only involve the management of asthma alone, but it also involves the adequate management of these underlying comorbidities which can make asthma difficult to control. Let us come to the diagnosis of bronchial asthma, right? So, the first test that we do is the pulmonary function testing. So, what are the findings that you will see in a pulmonary function testing, right? So, here we will see that the PEFR, which is the peak expiratory flow rate, will be reduced, right? So, we know that bronchial asthma is an obstructive airway disease, and hence the peak expiratory flow rate will be reduced, and the obstruction is more so during expiration. Alright, fine. And if you draw a flow volume curve, so you will see in the chapter on pulmonary function testing that when the patient does a pulmonary function testing, he is asked to blow into the apparatus in a single breath. So, he has to blow for at least 6 seconds, right? So, if you see this curve, you will see that the curve has reduced, right? The height of the curve has reduced, and this is because of the obstruction, okay, right? Then, what are the other parameters that you measure in a pulmonary function testing? You see the FEV1 by FVC ratio. Okay, so what is the FEV1? FEV1 is the amount that he has expired or the flow in the first second, right? So, this is the time, this is the flow, and you can see that in the first second, this is your FEV1. Okay, so we can see that the FEV1 is reduced. So, the FEV1 is reduced, right? So, if this is the normal, this is the bronchial asthma curve, we can see that the FEV1 is reduced. And the FEV1 by the FVC, the forced expiratory volume in the first second, by the forced vital capacity ratio, that ratio is also reduced. So, FEV1 by FVC is reduced in bronchial asthma. Okay. Then you also look at something called as the flow volume loop. So, in the flow volume loop, here you have an inspiratory loop and you have an expiratory loop. So, this is a normal flow volume loop. Okay, so this is what is normal. But in asthma, what do you see is that you find a scooping of the expiratory limb, or you find a scooping like this of the expiratory limb, right? So, if you just draw it again, you will find a scooping of the expiratory limb. This is the inspiration, this is the expiration, and this is what we call as the dog leg appearance. This is what we call as the dog leg appearance, right? So, a scooping of the expiratory limb is the characteristic finding that you find in the flow volume loop in the pulmonary function test for an obstructive airway disease. The most important highlighting feature is that bronchial asthma should be differentiated from COPD on the basis of one particular test, which is called as bronchodilator responsiveness. Right? So, bronchial asthma can be differentiated from COPD because of the fact that there is a bronchodilator responsiveness. So, every time that a patient undergoes a pulmonary function testing, he is administered a bronchodilator, especially a short-acting bronchodilator like salbutamol. So, once the salbutamol is administered to the patient, then you can see that there is an up to more than 12% increase in the FEV1 to an absolute value of more than 200 ml. So there is a more than 12% increase in the FEV1 to an absolute value of more than 200 ml, then this means that he is a bronchodilator responder. So if bronchodilator response is present, then this means that this is a definitive bronchial asthma. Okay, so this is about the various PFT findings in bronchial asthma. So the first test that we will do for the diagnosis of a bronchial asthma is a pulmonary function testing. Second, if the PFT is negative, you will have to do an assessment of airway hyperresponsiveness, and this is brought about by a methacholine challenge test. So methacholine basically stimulates your airway hyperresponsiveness. So there will be a 20% drop in the FEV1 to an absolute value of less than 400. Then this is methacholine challenge test positive. So here the FEV1 reduces because of methacholine inducing the bronchial constriction. Okay, so this is about the methacholine challenge test. Okay, so this is the cornerstones in the diagnosis of bronchial asthma. Then what are the other tests which can help in supplementing the diagnosis is the serum eosinophil counts. Most of the asthmatics have a elevated serum eosinophil count. Okay, then total serum IgE levels will also be elevated, especially if this patient has a type 2 type of inflammation causing the asthma, and more than 1000 if it is present, it is more indicative of a ABPA, especially in a difficult to treat asthma patient. So in difficult to treat asthmatics, you will find that the total serum IgE is more than 1000. Okay, and if the serum IgE levels are elevated, it also indicates that you can use anti-IgE mediated therapies like Omalizumab in the management of asthma, right? Apart from that, the next test that we do is the fractional exhalation of nitric oxide, and if these levels are more than 35 to 40 parts per billion, then it indicates that they are candidates for inhalational corticosteroid therapy. ICS stands for inhalational corticosteroid therapy. Okay, so these are the other adjuvant tests which can be used in the diagnosis of bronchial asthma. Then what about the chest X-ray? Always remember that the chest X-ray is normal in an asthmatic patient. Unless you may find evidence of pneumonia and so on, chest X-ray is normal even during an exacerbation of asthma. Clear? So this is about the various diagnostic tests. So let us move on to the management of asthma and let us understand what are the goals of asthma therapy. So the first goal is that we'll have to reduce the symptom frequency to less than 2 times a week. So main aim is reduce the asthma exacerbation frequency, symptom frequency to less than 2 times a week, and reduction of nighttime awakenings to less than 2 times a month. Okay, so reduction in symptom frequency to less than 2 times a week, reduction in the nighttime awakenings to less than 2 times a month, reduction in reliever use to less than 2 times a week, and then not more than 1 exacerbation per year. Then optimize the lung function, maintain the normal activities, and the patient should be satisfied with minimal side effects of treatment. Okay, so these are the major goals of asthma therapy. Reduction in symptom frequency to less than 2 times a week, reduction in the nocturnal awakenings to less than 2 times a month, reliever frequency use to less than 2 times a week, and not more than 1 exacerbation per year. So before we move on to the drugs which are used in the management of bronchial asthma, always remember that asthma is well controlled if you remove your allergens. So be very careful and counsel the patients about the different allergens which can trigger the asthma, and ensure that they are masked up and their allergen exposure is reduced, and also help them identify the triggers. So allergen management is very important. Second, always manage the co-morbidities which can worsen the asthma. Like if this patient is obese, patient has a component of OSA, patient is a smoker and he has a component of COPD, then please educate the patient and try to reduce weight, try to stop smoking, and give a CPAP if the patient has a severe obstructive sleep apnea, and weight reduction. So all of these measures and management of obesity, management of GERD will help in bringing down the exacerbations of asthma. Similarly, if the patient has a chronic sinusitis and postnasal drip, ensure that the ENT surgeons are involved, and that is also brought under control. Okay, so management of your triggers, management of your comorbidities becomes very important as a part of your asthma management. Then the specific drugs which are used. The first class of drugs which are used in the management of asthma is your bronchodilators. Okay, so bronchodilators help in relieving the obstruction. So first amongst these is your short-acting beta agonists. So what are your short-acting beta agonists? They are salbutamol. Okay, so they are beta 2 agonists, short-acting. For example, your salbutamol. Okay, fine. Then we have long-acting beta 2 agonists, which are your salmeterol and formoterol. So they are called as LABA. Okay, short-acting beta agonists such as salbutamol and terbutaline are called as SABA. Okay, short-acting beta 2 agonists usually start their action within 15 to 20 minutes and the duration of action is usually up to 4 to 6 hours. Okay, so they can be used during an acute exacerbation of asthma when you need an immediate reliever. Long-acting beta agonists on the other hand, which is salmeterol and formoterol, have longer action which includes a duration of action of about 12 hours to up to 24 hours. Then we have ultra long-acting beta 2 agonists like indacaterol, vilanterol. Okay, so these have a duration of action that can go up to 36 hours, right? So this is about the first group of drugs, which is your bronchodilators, short-acting, long-acting, ultra-long-acting beta agonists. What are the side effects of beta agonist therapies? We know that the beta agonist can cause shift of potassium into the cell and hence they can cause hypokalemia, right? So be very careful when the patient of bronchial asthma is on long-term inhaled beta agonist therapy or you're treating the patient as an inpatient for acute exacerbation, you can develop hypokalemia. Then secondly, beta agonist therapy can cause tremors and it can cause tachycardia. Okay, so use it with care in patients with an underlying DCM, dilated cardiomyopathy or heart failure. The second group of drugs is your anticholinergic agents, which are your long-acting muscarinic agents or LAMA. So what are the examples of this? They are your ipratropium and your tiotropium. So these also act on the airway and they help in acting as bronchodilators. The third group of drugs is theophylline. Okay, so theophylline was used prior, but now because of its increased drug-drug interaction and its tendency to cause tachyphylaxis, it is not commonly used these days. Fine. So predominantly we manage it with bronchodilators, which is your beta agonist and your long-acting muscarinic antagonists. Then the next group of drugs which are used is your leukotriene modifiers. Okay, so what are your leukotriene modifiers? We have your montelukast and zafirlukast and so on and so forth. So leukotriene modifiers have no role in acute exacerbation. Leukotriene modifiers have no role in acute exacerbations. They are more commonly used in patients or more useful in patients with exercise-induced asthma. In patients with exercise-induced asthma, or if they have a concomitant allergic rhinitis component, in those conditions you can use a leukotriene modifiers as add-on therapy to your inhaled drugs. Okay, then the fifth group of drugs. So in patients who have elevated IgE levels, anti-IgE therapy can be used and the drug is Omalizumab. So Omalizumab is useful in patients where the IgE levels are more than 30 and they have an eosinophilic type of inflammation with peripheral eosinophilia or eosinophil counts more than 260. So this is given as subcutaneous injections about once in 2 to 4 weeks. Okay, so that is your anti-IgE Omalizumab. Then the sixth group of drugs that can be used is your interleukin 5 blockers. That is the reason why we should be knowing about your type 2 and your non-type 2 mediated inflammation pathways. So under your type 2 inflammation pathway, we had learnt about interleukin 5, which is responsible for stimulating the eosinophils, right? So interleukin 5 blockers, we have Mepolizumab and Racilizumab, and interleukin 5 receptor blocker, which is Benralizumab. Okay, so this is about interleukin 5 blockers. Okay, right. So apart from this interleukin 5 blockers, we also have interleukin 4, interleukin 13 inhibitors like Dupilumab. Okay, so these are the newer drugs which are used in the management of bronchial asthma. So now we will look at the GINA guidelines 2024 in the management of bronchial asthma. So how do you approach, right? So bronchial asthma treatment should be a personalized approach, right? So always remember that you will have to assess the patient, you confirm the diagnosis if necessary, you do a symptom control, look at the modifiable risk factors, the comorbidities, and then only try to intensify the treatment. Okay, and also you ensure that every time a patient visits you, you check the inhaler technique, right? They are using the right dose of the inhaler in the appropriate technique. So this has to be taught, and this has to be taught to the patient time and again. And adherence as well. Always ensure that the patient is compliant to the medication. Then you try and adjust, see if non-pharmacological strategies of including education and skills training can be thought of, and treatment of the modifiable risk factors must be ensured. And then you review the medications, and then you go up on the medications. Okay, so there are two tracks of treatment for bronchial asthma as per the GINA guidelines. So the first track is the preferred track because it has been found to be more effective. So this includes what type of treatment? This is an ICS-formoterol. Okay, so this involves what type of medications? It involves in ICS-formoterol combination treatment, right? So that is the track 1 and preferred one. So what is the advantage of using this ICS-formoterol combination is that this itself can be used as a combined reliever as well, right? So what is the basis of this is that if the patient is on an SOS basis of need of an inhaler, you can use ICS-formoterol itself as a reliever therapy. Or if the patient is having multiple exacerbations and you will have to give them a continuous or a prolonged inhaler at home and use a reliever as and when required, then the same ICS-formoterol can be used as a daily treatment and it can be used as a reliever as well whenever the exacerbation increases. So the same drug can be used as a reliever, and this is the additional advantage of using this ICS-formoterol. Okay, so we use aspirin when a patient gets admitted. So that is a short-acting beta agonist. So remember that short-acting beta agonist is not a part of the track 1 or the preferred therapy. The preferred therapy is an ICS, which is an inhaled corticosteroid along with a combination of formoterol, which is a long-acting beta agonist. Inhaled corticosteroid with long-acting beta agonist is a preferred regimen. So the first step would be as and when needed only treatment of low dose ICS-formoterol. Then step 3 will be you give them a maintenance therapy of ICS-formoterol itself, and at any stage the patient has an exacerbation, the reliever will also be the same ICS-formoterol. So for example, you are using a 4-Ocort inhaler. If you all are an asthmatic, you will know. If you use a 4-Ocort inhaler or use a Symbicort inhaler, then this is only used as maintenance therapy and this itself is used as a reliever therapy. Okay. Step 4 is you increase the dose. If there is no improvement, they are still continuing to have nocturnal exacerbation and the goal of asthma is not met, then you change it to medium dose ICS-formoterol. And step 5 is if they are not improving on this as well, then only you add a long-acting muscarinic antagonist like a tiotropium, or you can also try your anti-interleukin 5, anti-interleukin 4 inhibitors and so on. Okay, so this is the preferred track. So maintenance ICS-formoterol, reliever ICS-formoterol. The alternative track is that you have a different controller therapy or a maintenance therapy and a different reliever therapy. Okay, so what is this? This is a ICS-SABA combination. This was the older regimen which was used and it is often used by most of the patients even today. But this is not the preferred therapy as per your GINA guidelines. So what we use here is an ICS-SABA. That means you have your aspirin nebulization SOS. That is when we give them, whenever they have an exacerbation, you give them aspirin, right? So take an ICS whenever a SABA is taken, right? So you always remember in asthma, the backbone of therapy should be an inhaled corticosteroid. We do not give only salbutamol nebulizations or salbutamol inhalers, okay, right? So whenever you take an inhaled corticosteroid, whenever a salbutamol is taken, always give an inhaled corticosteroid along with this. Step 2 is low dose maintained inhaled corticosteroid. Step 3 is low dose maintained ICS-formoterol. And then in step 4, you use a medium or high dose inhaled corticosteroid, right? So here, what is the difference is that the reliever is often an ICS-SABA combination or an as and when needed SABA alone, right? So you will think of zero flow, right? Zero flow. So here, these kind of inhalers are not part of first track, rather they are part of track 2, okay? So here in track 1, it is an ICS-LABA combination. Here the drugs for a maintenance therapy versus a reliever therapy is different. The maintenance should always have an inhaled corticosteroid backbone, and it can be an ICS alone or an ICS-SABA combination. The reliever can be SABA alone or an ICS-SABA combination. Step 5 is you can add a long-acting muscarinic antagonist like tiotropium, or your subcutaneous injections can be used. Okay, fine. So that is a difference between your track 1 and track 2, and how do you manage bronchial asthma as per your GINA guidelines. Now, let us move on to the last portion of your bronchial asthma management, which is acute severe exacerbation, which is called as status asthmaticus. So when a patient presents with severe exacerbation, how is he going to appear? So the patient is going to appear very tachypnic, respiratory rate more than 30, heart rate more than 120. Patient is unable to complete sentences, right? And when you do an arterial blood gas analysis, the ABG-PaO2 is less than 60. He is hypoxemic, and if you do a peripheral saturation as well, he is hypoxic. The PCO2 is elevated. There can be elevated levels of carbon dioxide, and pulsus paradoxus is a characteristic pulse finding that you will find, and very importantly, the patient may even have a silent chest. You may not even find bronchi, you find a silent chest. So if these characters are present and the patient is not responding to the inhalers that he was taking at home, then this is your status asthmaticus or acute severe exacerbation of bronchial asthma. So how will you manage this status asthmaticus? The first step is always look at the airway breathing and circulation. So you look up at the, do a proper examination, look at the saturation, look at the heart rate, and you give them supplemental oxygen if it is required. If the patient is extremely drowsy, if the patient's TCS is low, or if he is not able to breathe at all, the respiratory rate is dropping, then you intubate the patient. Okay, right? And also connect them on IV fluids and maintain the blood pressure adequately, ensure that there is no hypotension, and always administer the first dose of antibiotic if you are suspecting that this may be a bacterial infection which has triggered the asthma. As far as the medications are concerned, the first medication that you will have to give is your nebulization short-acting beta agonist. Nebulization short-acting beta agonist, right? The second would be again a nebulization with steroids. Nebulization with steroids, and most of the time if they do not respond to your inhaled steroids, you may have to give a systemic corticosteroid like a hydrocortisone, which you give 100 to 200 mg IV. Okay, right? So you give a nebulization short-acting beta agonist, nebulization steroids, systemic steroids, and your first dose of antibiotic. Okay, fine. So you keep on frequently monitoring the patient, put them on continuous nebulizations, and keep monitoring your ABG every half an hour. If there is improvement, your ABG has improved, your saturation has improved, patient is symptomatically better, tachypnea has come down, then well and good, continue the same line of management. If there is no improvement thereafter, the second line management will include IV magnesium sulfate, which is given 1 to 2 grams slow IV over 20 to 30 minutes. Okay, fine. Now, if there is no improvement even with this, the ABG is not improving, patient's condition is deteriorating, then by now you will have to look for alternative ventilations, which includes a NIV or a high flow nasal cannula. A NIV is useful in bronchial asthma, especially when the PCO2 is elevated. A non-invasive ventilation, especially like a BiPAP, will help in removing your excess accumulation of carbon dioxide, right? If there is no improvement with this as well, by now you will have to intubate the patient. If the respiratory acidosis is worsening, intubate the patient and put them on inhaled anesthetic agents, ketamine, heliox therapy or nitric oxide therapy with your salvage treatment for status asthmaticus. Clear? So this is about your status asthmaticus. So with this, we have come to the end of our chapter on bronchial asthma. We had learnt about the epidemiology, we had learnt about the triggers, we have learnt about the clinical features, and we have learnt about the management as well. Thank you.